Good morning, everyone, and welcome to Grand Rounds. I'm Mary Ottolini, the Vice Chair of Education, and my co-presenters today will be Dr. Robin Steinhorn, Dr. Mark Weissman, and Tamara John. And our objectives are going to be divided between the different presenters. My job will be to convince you that participating in MOC Part 4 QI activities can really be helpful to you in combating burnout. And I don't have a slide of disclosures, but I must disclose that I am probably not the best person for my current job role, which includes enforcing rules, because I don't like rules unless they help me. So I think I have been convinced that this rule about MOC4 is actually good for me, and I want to convince you that it's good for you as well. And then Dr. Steinhorn is going to talk about how recent changes to the ADP have made it easier and more meaningful for you to get MOC4 credit. And then Dr. Weissman and Tamara are going to talk about recent and ongoing work here at Children's National around QI across the continuum here at Children's, and how we can use this work to help ourselves and to help our patients. And then the fourth point is just to remind you that you can get QI credit and MOC4 credit for educational and research quality improvement as well as clinical quality improvement. So I'd like to begin, because I like to begin Grand Rounds with something that's clinically relevant. And so I'd like you to take a look at these pictures of patients, and then to answer this question: what do they all have in common? And we can, since we have a relatively small audience, we can try using poll everywhere, or we could just raise hands. So maybe we'll go low tech. How many say A, meningococcemia? B, they've all been cared for at Children's National in the last 5 years. C, they all have an immune disorder. D, they all have a rare disease. Or E, they all have a malignancy. So the correct answer is actually D, they all have a rare disease. They all have H. flu type B, which is currently a rare disorder. And back when I was a resident, H. flu was very common and was a real serious cause of morbidity and mortality in previously healthy children. It was a horrible infection for children to get. Likewise, we didn't have surfactant when I was a resident back in the 80s, and if one of your patients had ALL, it was horrible because it was like giving a parent a death sentence. And all those things have just changed so wonderfully in the past 35 years that at the end of our workday, we should be feeling like this, right? How many people in the audience feel like this at the end of the workday? All right. We will give you more work to do that. Unfortunately, this seems to be the trend nationally, maybe not here at Children's, but it seems like there's increasing problems with burnout. And burnout is basically, I know we've had some Grand Rounds about this, but according to Maslow in the Burnout Inventory, it encompasses 3 major dimensions. First, it's a work-related state characterized by emotional exhaustion, depersonalization, characterized by cynicism and negative feelings toward others, and a feeling of a lack of personal accomplishment. So the only one that doesn't fit here is distrust. And this 22-item survey can actually be summarized into two phrases. I feel burned out from my work, and I've become more callous towards people since I took this job. So why is burnout a problem? Well, there are personal issues, and actually one of my good friends just started in her job as DIO at NYU a few years ago, and that same month that she started, 2 of the residents jumped off the roof and committed suicide. So thankfully, that's not a problem that we have here at Children's, but we know that's the tip of the iceberg, and we know that depression and burnout are underneath it, and we want to do everything we can to protect our trainees and to be role models for wellness for them as faculty. We also know that in terms of our institution, it's bad for business. It's bad for patient care. It costs money to replace faculty when they're burned out and leave. And if you look at pediatrics and pediatric subspecialties, they're relatively protected compared to adult specialties. And that's probably, I'll tell you a bit about combating burnout, but it probably has to do with the meaning we find in our work every day. But still, what this slide depicts is an increase from 2011 to 2014 across the nation in the percentage of burned out physicians. Perhaps this picture can shed some light on reasons for burnout. As this depicts a child at their seven-year-old at one of her pediatrician visits, and I think maybe as you can see over here, the patients seem to be having a good time, whereas the pediatrician seems to be smiling while they are documenting on the EMR. So when it comes to depersonalization, perhaps this gives us a clue. Contrast this with this classic picture called painting called The Doctor. It was painted by Luke Fildes in 1890, and it portrays his physician, Dr. Murray, who cared for his child, who tragically died at a year of age. So imagine what it was like to be a pediatrician in 1890. You had so little to offer your patients, but clearly depersonalization was not a concern. So in terms of our residents, our interns' experience here at Children's National, we recently published an article in Pediatrics where we did a real-time work sampling study of the amount of time our interns spend on various activities throughout a 12-hour day. And as you can see, the majority of their time is spent with the electronic medical record or answering pages, talking with members of the healthcare team. This green slice depicts the amount of time they actually spend with patients and families, and purple is time that's spent on educational activities. So we also asked them to rate the perceived value of these activities, and they rated these activities here much higher than these activities here, particularly interacting with the EMR. So I think we have a challenge to really try to balance this need and desire for physicians, nurses, trainees to be spending more time with patients, because that's what brought us all to medicine, and to figure out how to make the systems that support us and allow us to practice such high quality and to be able to have such good outcomes for our patients. But we need to figure out how to make these systems work best for us. And so looking at causes of burnout, there are personal factors which can be addressed through a variety of means, and I don't want to minimize those, but I want to focus today on organizational factors and how, again, quality, knowing kind of the tools of improvement science can help us to have a sense of control and to be able to improve the systems and make them work for us. So the Mayo Clinic has really been a leader in terms of looking at physician wellness and burnout and looking at organizational contributions. There is burnout on the one hand and engagement on the other hand. And meaning at work is at the center of this. It's estimated that if physicians spend 20% of their time in meaningful activities, it's a huge counterbalance to burnout. And then some of these other things like efficiency and resources, workload and job demands, control and flexibility, if we can enhance those through enhancing our systems of care, I think we can really help to combat burnout. And just to make a plug for a project that we're involved with, it's called an ACGME Innovation in Education project, where We are one of 8 institutions. We're the only children's hospital, and they're looking to us to kind of be a model for how do we engage our trainees, in particular in quality and safety initiatives. But in order to do that, it's been demonstrated here and at other institutions across the country. Do you know what one of the biggest barriers is? Faculty. Faculty we didn't learn quality improvement when we were residents, and I think there's been a significant amount of cynicism in the way MOC4 maybe was initially presented in really engaging us in learning QI methods. But, I'd like to challenge all of us, if we want our trainees to be engaged in this and we want them to be part of the solution to burnout, we need to engage ourselves and learn about quality improvement and work with them to practice it and to get MOC4 credit for it. Thanks. Turn it over to Rob.
So I'm here today to talk to you about this from the perspective as somebody who participates in maintenance of certification through the American Board of Pediatrics. And in full disclosure, I am a member of the Board of Directors for the American Board of Pediatrics. I represent the American Pediatric Society on the Board of Directors. And I could not, and my final disclosure is I could not find my bulletproof vest this morning to put under my jacket, so go easy on me. I'm going to review with you where the American Board of Pediatrics is. I not only represent the board, but I really seek your feedback, and that's a very important outcome for me of this grand round. So this is to remind you that the North Star for the American Board of Pediatrics is not really different than what our North Star is. It's about healthier children and delivering the health care that creates that kind of outcome. So the mission of the American Board of Pediatrics is to the public, it's to the children of our country, and it's to certify pediatricians based on standards of excellence that lead to high quality care. It assures the public that every pediatrician that they interact with fulfills these evaluation requirements that encompass the 6 core competencies. So MOC has 4 parts to it. I'm going to focus on the last 2 and mostly on part 4. So part 1 should be pretty non-controversial, that it's professionalism, retaining unrestricted licensure, and there is some work that's not a terribly high bar. There is some work afoot on how we should be thinking about that over the next decade. Part 2, again, is something that we're all doing by sitting in this room. We're maintaining life learning and self-assessment. The concept is to understand where your weaknesses are and address them. I think the work that the board is doing is trying to make sure that as you do the activities you would normally do, so as you attend conferences that are certified by ACCME, including activities such as grand rounds, that those will translate over to your Part 2 activities, and that will be easier and easier for you to accomplish as you go through your cycles. Part 3 is the cognitive knowledge. This has been a highly controversial aspect of it. How many of you have gone to take your secure exam? I have. For me, it was a real moment when I was taking my secure exam, and I had headphones on, and so I took my earrings off because they were digging into my neck, and I immediately had 2 security officers next to me escorting me out. worried, I guess, that I had cameras in my earrings to take pictures of the screens or something like that. So I think a real step forward that I'm going to review with you is that while the initial certifying exam will continue to be a proctored, secure exam, MOC activities are going to fit better into your life. Part 4 is what we're really here to talk about today, and again, the goal here is to be really making this work with the activities that are meaningful, the activities that Mary so nicely described that make us feel really good at the end of the day, and I'm going to give you an example of that at the end. So this is the part 3, the cognitive expertise, and you can see here I became initially certified in neonatal perinatal medicine in 1988. So you can see I feel like I've been an early adopter for each of these evolutions of MOC. So there were the what I call the glory years, where we had open book exams at home. Apparently there was enough cheating going on with those open book exams, with people not taking their own exam, that's what migrated us to a secure exam. I've already told you that has been a controversial and not entirely successful piece of assuring that every pediatrician has and maintains that expertise. And so there is a pilot now called MOC Peds. How many of you are participating in MOC Peds? Okay. And so MOC Peds is, I think, a step in the direction that will, again, make maintaining your knowledge base in pediatrics fit much better with how we normally learn and make sure that we've really gained that knowledge. So what this will be is that every year, this will be a continuous process, but every quarter of every year you will have 20 questions pushed to you, and you have 3 months to answer those questions. It is an open book exam, but it's time limited, where you will have 5 minutes to answer every question. So far the feedback is 5 minutes is plenty. And you know in advance what those 20 questions will be covering. So the idea there is that as new guidelines come out, you will know that the 20 questions will focus on the new guidelines. You will read the guidelines and then have questions that relate to those guidelines. So again, it's going to synchronize the kind of work that we all expect of ourselves, and just we show that we've been able to do that. So it will be much more convenient to you. You won't have to drive to a testing center. I won't have security officers trying to escort me out again. So I'm going to spend the rest of my time talking about part 4, which is our improvement in medical practice. And so these activities really derive from the ABMS, and I see some of you in the audience who will not be in the American Board of Pediatrics, will be in anesthesiology, radiology, other specialties, but all have this requirement for quality improvement activities, and to make sure that every diplomat has that knowledge base in what quality improvement is and can actually practice quality improvement. So I think the American Board of Pediatrics and some of the other boards deservedly took a black eye over this. And again, I told you I've been an early adopter for every phase here. And so the options at the beginning were very few. And I remember we had just finished a hand washing campaign. We had just gotten our neonatal intensive care unit up to 99% compliance. And when I went to do this first cycle of part 4, it turned out I got no credit for that at all. I had to take an online module and sort of invent new hand washing data over a period of 6 weeks to get credit for it. It felt, frankly, kind of silly and ridiculous to me, but there were no other options at that time. because any portfolio sponsor, that was a very lengthy application. So what has changed? The QI is now a part of the daily work in many of our settings, required by the Joint Commission, required by our payers, required to set up a patient-centered medical home. So it's something that all of us in this audience are doing every day. How do we make sure we can capture that for the Part 4 credits? So the American Board of Pediatrics is really working hard to recognize that work that we're already doing, and so new pathways have been created in the last couple of years. So it now really is a much more expansive and inclusive process. It's awarded for the application of QI science and methods to any process intended to improve the health of children. I think Mark's going to give a great example, and I suspect Rahul is as well. And it will also encompass some of the research that is done in institutions such as ours. So I'm going to talk a little bit about how we have used the Part 4 process to improve a very important quality initiative here at Children's National. This one has been led by Nathan Dean, assisted by Emmanuel Gaber-Mariam, and this has to do with late rescues. And late rescues are those children who are out on our acute care wards who either are admitted to the ICU and they need emergent intervention with intubation or pressors, or those children that have a code event and need those interventions out on the floor. This is something I hope we would all walk out of the room agreeing we would like to drive to zero. And we have made huge progress in a very short time, in part because of the engagement of many people. And these are the people that have submitted for and received Part 4 credit, which is a very now easy, seamless process. You see my name on there. Actually, you don't, but I've done this as well, working with Dr. Dean. Very easy to get my Part 4 credit. And many of the people on this list have received multiple cycles of Part 4 credit. So the goal is to have zero codes outside the ICU, and our goal in FY17 was to drive those code events down by 50%. With our key drivers of appropriate level of care, situational awareness, escalation, and resources and competencies. So this group of individuals was able to break this down. This shows the work that has been done to date and work that is still in process with a double asterisk. So the appropriate level of care, making sure every child is in the environment where he or she can get the what is required. That situational awareness, we worked very hard on that to make sure that we have teams of individuals working at the bedside, really anticipating where the next problem might be coming from, activating teams, the rapid response team to evaluate children before it becomes a code situation. Escalating as needed to senior residents and to an attending such that no child gets transferred to the ICU without the attending having been involved in advance, and making sure that our nurses, residents, fellows, and attendings have the competencies that they need. And this includes early recognition of sepsis and shock, as we talked about a few weeks ago when Dr. Zimmerman was here. So here's our results slide, and I have to tell you, this is really impressive work. This is hard cultural change for a hospital. So in FY15, there were 16 code events outside our ICUs, and this phenomenal team with people working hard, analyzing individual cases, coming back together and driving that change, was able to drive those code events down to 5 in FY17. So that is a 69% reduction in a little over 18 months. And now the average time between code events is 64 days. And we've had some that are even more than 5 months between code events. So the group this year is now working on late rescue interventions. I know I saw Mary Patterson walk in. I know this is a topic she's very passionate about in terms of our simulation and the systems we will wrap around these children. And so our goal is to have fewer and fewer children with a transfer to the ICU who need acute intervention, immediate intervention with intubation and inotrope. And so with that, I will turn the podium, I think, over to Mark and Tamara.
Great results. Hi, folks. This is Tamara John Lee, also known as TJ, so it's the same person, although she does the work of many folks. Let's see if we can find her. And we are a bit of a tag team. Whatever. So I think part of what we are really trying to do here is help move quality improvement from what folks may just see as a task that doesn't necessarily align with what we do, and really help folks appreciate that this is part of medicine. This is part of continuous improvement, is part of making healthcare better for our patients, for our families, and for our care teams. And I think the Board of Pediatrics and the professional societies are also doing their continuous improvement cycles to try to get the training and requirements of what we do sort of better align with sort of the process of board accreditation, certification, and recognition. So as I look out over our audience, I see a lot of brand new trainees in short white jackets. Just raise your hands for a sec. All right. And over in this corner here, I see some more senior practitioners. No, I'm pointing to you, David. And what I would point out is for you over here, what you learn in your rotations at Children's National, how many folks think you're going to be practicing medicine exactly the way you were taught it in your rotation in medical school? You're not. Science changes, knowledge changes, care changes, and somewhere along the way, we have to take what we were taught and what we were learned, and we have to apply new knowledge. And we have to move from the way we've always done it to doing it a new way. And that process of changing and recognizing and improving our care shouldn't be random, shouldn't be something that we guess at. It should actually be a skill set that we begin to learn and we begin to practice in our training years, and we begin to perfect over the course of our professional practice. So that part of our culture is recognizing that we should be looking at what we're doing, we should be measuring it, and as new knowledge comes along, we should be applying that new knowledge in sort of a learned, structured way, which is really what quality improvement is all about. And part of this was sort of galvanized around the turn of the century, and I mean the 21st century, because I trained in the last century, where, you know, we need to redesign 21st century healthcare to leverage IT, think about different payment models, paying for value, not just for churning, applying evidence-based and decision support and accountable care, and changing the way we do our education and training. We now practice in care teams, we leverage evidence, and our new culture is measuring and improving care, outcomes, and satisfaction continuously. So part of what we're really trying to do in this next segment is to do some cataloging of some of the early quality work that we have done. And TJ and my hope with Robin and Mary is that, you know, at the end of the session, It's not that you look at these projects and say, oh, I can do that project. It's more that you think about the work that you are doing and the improvements that you need to make and say, oh, I can do that in my space. I can do that in my inpatient unit. I can do that in my specialty outpatient practice. I can do that in my primary care setting. So what we want to do is talk a little bit about sort of this shift. So we're shifting from traditional CME learning, where it used to be you just counted the number of hours where you went to lectures, to actually demonstrating that you're being part of initiatives where you are measuring and improving the care that you are doing. And Children's National actually has a rich history of sort of working in the quality improvement space. Back in 2005, we actually set up a citywide quality improvement infrastructure and partnership, the DC Partnership to Improve Children's Healthcare Quality. We didn't invent it. We were coached by other experts out of Vermont and a National Improvement Partnership Network. And one of the nice things about quality improvement is people are sharing techniques and best practices so that you can apply them in your local setting. The focus of this is actually beginning to try to apply quality improvement not just at the point of care, but across systems of care, whether those are cities or states or health systems. And a lot of our early work was actually in the community space. And then we have returned more to the hospital setting. So we got seed funding from the Commonwealth Fund to set this up and develop sort of our quality improvement infrastructure. We funded this through our regional pediatric practice partnership, Children's National Health Network, and we sourced it, we resourced it out of our Goldberg Center, which is sort of our academic home. And we got Tamara and others, to help drive our quality improvement infrastructure. And I want to catalog a couple of the early projects just to sort of point out some of the work we did. The first work that we did was across inner city Washington, D.C., trying to improve preventive care, or EPSDT, early periodic screening, diagnosis, and treatment, mandated services for Medicaid-enrolled kids. And this wasn't children's alone. We partnered with DC Medicaid. We partnered with all the Medicaid managed care entities, the DC chapter, the AAP, and FQHC providers across the city. We got funding, actually, from the Medicaid plans to run a quality improvement learning collaborative. And the idea was that we would introduce, this was before electronic health records, we would introduce structured templates to sort of guide better preventive care services when kids came in for well child visits. And the benchmark in those days was sort of published that 40% of kids going for preventive services for Medicaid visits got what they needed 40% of the time. And we were able to demonstrate that if you were a Medicaid-enrolled child in the District of Columbia and for preventive care services, we delivered 80% of the time, so twice the national average. And the other sweet thing about this is that it was actually had a pay-for-performance incentive payout by the MCOs, and the MCOs paid out $350,000 to the various primary care practices for sort of hitting these benchmarks. And that was back in 2005 to 2008. We then did another project working with the city around improving immunization rates based on, again, a standard immunization series. We partnered with the FQHCs across the city, the DC's immunization program and registry, and also the Medicaid plans. And the idea is that we would look to improve immunization rates for infants between 19 and 35 months of age. This was a national metric, and the district wasn't performing up to speed. One of the interesting things is that we were doing this back in 2006. This was a population health quality improvement initiative. We were using a registry. We were using the city's registry, and we weren't actually looking at our records. The city was running its registry reports for every child in the district and sharing that with practitioners so that we could actually do a citywide improvement initiative. We were able to improve children's results by 16% because we're such a big provider. We raised the bar for the whole city by over 5%, and actually became one of the top performing states in the district. Linda Fu wrote this up for Pediatrics, and the CDC immunization program manager circulated it to every state CDC immunization program across the country as sort of models for improving care. And this was right around the time that MOC came out. And we didn't design this as an MOC study, but we were able to apply and get credit for this, which sort of galvanized where we were going. So I think it's important to sort of recognize that MOC is not a four-letter word, you know, and that this is part and parcel to where we are going in terms of not just training today's generation of learners, but this really needs to become a core competency of current care providers. This just needs to become part of our culture. And Robin sort of detailed sort of the evolution of MOC, and I'm not going to spend a lot of time on that. There is a framework. It does basically involve figuring out where you're at, figuring out where you want to go, what the best practice is, measuring your baseline, and then figuring out, there are lots of places across our care enterprise where we decide, well, we need to put this in place, or we need to improve that. But as a general statement, I think too often it's like, well, if we just write a protocol, it will automatically happen. And we know life doesn't work that way. And so I think we should be approaching many of the enhancements and improvements that we need to make through quality improvement process, where we basically measure where we're starting and say, well, let's try it this next month, remeasure, see where we're at, and do these through continuous cycles. And if actually you set out an aim and you measure where you begin and start and document who's been involved, you actually can get MOC credit for all the folks that are participating in that meaningfully in that initiative. So SMART aim, an effective aim statement, having some measures of what you are changing and what your outcomes are. Balancing measures are basically, so if we put this change in place, are there any unintended consequences or things that could happen that are maybe not a good thing? And so identifying potential balancing measures. And then having some process to capture and report the data and use the data to improve your care. So this is sort of a catalog of community-based projects that we've done. Beyond immunizations, we've done work in obesity, asthma care, mental health screening. We've worked with the Maryland AAP chapter to do autism screening in community practice, transition planning for kids with epilepsy. Rachel Moon took the same model out to birth hospitals across the country about safe sleep training and breastfeeding support. So there's just a lot of different directions you can take this, and then we'll show you a little bit of what we're doing inpatient. So it's no longer a secret. You know, this is just part and parcel of what we do. These two slides up here are year 1 and year 2 of asthma projects. Each one of those dots is a private pediatric practice that agreed to sort of participate with us and participate in measuring where they're starting, trying practice changes in their office, participating in web conferences to improve their asthma care. We did the same sort of work in the District of Columbia. If we can work with private practices or public clinics across the Mid-Atlantic, almost certainly we can work across different floors in our hospital to do a similar sort of improvement initiatives. The obesity initiative basically was looking at metrics that sort of define recommended obesity screening and counseling in primary care practice. This also actually is a quality measure for payment by the managed care entities. So being able to move practices from a low point to a high level is good for screening, good for the kids, and actually good for practice recognition from a quality and payment perspective. The work that we've done with asthma care also is sort of focused on appropriately classifying kids by severity and control so that we can get the right care in place. And we were able to demonstrate significant improvements across 250 providers and 50 practices in the Mid-Atlantic region. We did a follow-up initiative that actually focused on more detailed data so that we could stratify kids in our practices by severity and complexity so that we could begin to do population health work and target different layers of kids so that the high-risk kids got more aggressive interventions and the low-risk kids got less aggressive interventions. We did a citywide project to introduce a screening for mental health concerns across every primary care practice in the district. This was a citywide partnership. This is an area where many of our practitioners felt unschooled and unready, and so we did coaching and counseling for our practitioners and able to demonstrate that we are now screening at the majority of our visits, identifying large numbers of kids with mental health concerns, and beginning to get the right services for those kids. The other thing that we opted to do in the primary care space is we did some work actually about payment and reimbursement and look to improve that as well. So part of the reason to do that snapshot is to demonstrate that these shouldn't be one-off projects anymore. Part and parcel to whatever part of the care continuum that you are working in, you should be thinking about how, what are we doing today? What are our metrics? What are the best practice recommendations? What is the gap between what we should be doing and what we are currently doing? And if we're going to start making some changes, how do we begin to do that in a structured way where we introduce quality improvement, learning principles, and measurably improve what we are doing? And oh, by the way, you get MOC credit for doing that. This is not about how do I go get my MOC credit. This is about how do we change our culture, how do we embed quality improvement into the work that we're doing, and do it in a way that really is meaningful to our care teams, meaningful to our families, and gets us the recognition that we're looking for from the Board of Pediatrics. So we have been doing a lot of work across the community. We are working with partners across the country. But I think part of what we're really also trying to do is sort of figure out how to raise our game here inside Children's National as an academic center and make this even greater part of our culture. And I was going to bounce the ball to TJ, who's going to at least catalog some of the early work and early collaborations we're doing in some of the inpatient settings.
So, again, my name is Tamara, or TJ, and you will probably hear my name floating around when it comes to MOC in the American Board of Pediatrics portfolio work. So, we really weren't shouting from the rooftops that we were a portfolio sponsor for American Board of Pediatrics, just because we know that there was a lot of controversy on how people viewed doing quality improvement and trying to get credit and all this extra work. However, there were a few intrepid providers in the hospital who called me and said, I heard that we were a portfolio sponsor. Tell me about this MOC thing. And that is how our conversation kind of goes for a lot of the folks who have approached me so far. So I'm not going to talk too much about this because Robin did a very good job explaining the Late Rescue Collaborative, but Dr. Dean was the first provider who reached out to me about getting MOC credit for the work that he had already kind of put in place. So he had a driver diagram already. He had a plan of implementation. He wanted to do this work. or he was already doing this work and wanted to just get some credit for the providers who were working with him. And we sat down with him, we went through the application, and it was a very seamless process for him. And he didn't think it was too difficult, and he said, oh, I should have done this a lot earlier. And that is our hope, going forward, that any activity that you are interested in doing, it's not too stressful to get credit. So another project that we are sponsoring through our portfolio is the Reducing Unintended Extubations in the Neonatal Intensive Care Unit with Dr. Lamia, who is in the audience, or she was. Hello. And she, she would come in through our office and she kind of randomly stopped by and said, hey, I heard you're doing your MOC portfolio sponsor. Can I get credit for this work that I'm doing? And so we sat down with her, we went through her project and her ideas and what she was thinking. And we said, sure, as long as you're documenting how people are meaningfully participating and you kind of track your data across time and you tell me what you were doing, we can make this work. And, she's been doing this, and I don't think it's been too difficult for her. And it's already work that she was doing, and she's just getting credit for it. So, we try to make it easy for you because we know you have other things on your plate, and we don't want this to be burdensome. So this is just an example of providers who have, heard through the grapevine that we are offering MOC credit for QI work. And we try to get them to get credit as best as we can. And I think the interesting one on this list right here is the nursing feedback from emergency medicine, which they just recently submitted an application for credit, and it's just 10 residents. So for those folks in the short white coats in the back, if you guys are doing QI work that you think is interesting enough and important enough to, share and get credit for, you can bank this MOC credit as well. So you don't have to start off with nothing. When you actually go into work or go full-time or when you graduate, there we go, you can start off with 25 points already off the bat. So, please take this as an example of things or projects that people are already working on and kind of realize that they can get credit for. Nothing is too small. Nothing is too long, nothing is too short. You can always reach out to us and we will work with you to figure out how we can either improve your process so that it meets the requirements for MOC credit or kind of just push you out along the way and say, yep, you're approved because you are meeting all of our standard requirements. So, are you ready to do your own MOC project?
Do that.
Okay. So, for the basic level of, getting credit, you have to be trying to improve at least one of the Institute of Medicine's quality dimensions, safety, I can't remember all of them at the time. Timeliness. It has to be relevant to your practice, so you can't be in the NICU and working on something in the community for, immunization. You have to have a standard quality improvement method. So you can use the lean process, which I know the hospital pushed out, or you can do the quality improvement process with PDSA cycles. So plan, do, study, and act, these really short, tests of change. You have to have some type of structure or organization, leadership infrastructure around improvement process. So you can't just, think, I have an idea and I want to do this and that's good enough. You have to kind of plan it out and have small PDSA cycles and really work through your work.
We can help.
And we can always help you with that. And then you have to document, yes, you can say I've done this work, but if it's not documented, it doesn't exist. So we only ask that you kind of track your improvements, your data across time, because that is how you learn. If you're just going from memory, it's not always the best. And then, you can always come to us for ABP, MOC credit, but we are also now a ABMS sponsor. So if you're not boarded by the ABP, you can always still get MOC credit from our portfolio sponsor with Dr. Shaw. And so if you have questions around, how you get MOC credit if you are ABP boarded, please feel free to reach out to me at any time, and I will love to sit down with you and go through the process and make sure that you are ready to go. All right. Dr. Shaw, did you want to say anything about the ABMS?
TJ last year, thank you, TJ. She is a godsend to MOC, helped us get ABMS. She is. All of you who work with her know that. Part for multi-specialty. So whether that's for otolaryngology or for surgery, and it's a really big step, and we look forward. As you said, you're not screaming from the rooftops, but now I think you just did. But I think we will start, probably in the next 6 to 9 months, start screaming from the rooftop about multi-specialty. We have a lot of projects here, and we want to start getting credit for that. And you're to thank for that, but that's all I wanted to say.
Well, the last thing I would say is that part of our credentialing here for medical staff is that folks maintain their board certification, which requires that folks participate in all the activities that keep them board certified. And MOC has been an area that some providers haven't paid full attention to in their 5-year cycles until, oh my gosh, I have to renew my certification and it's only 2 months away. Let me say that it is very hard to do these projects or get this sort of MOC credit as a last-minute rescue. The idea is that we are really trying to change our mindset and framework that this is part of what we do. Day in and day out. We bake it into our work. We measure it. We get the credit. And by the time the cycles roll around, it's a done deal. We're already squared away. For primary care, all the work we've done getting NCQA recognition in Goldberg Center and Children's Pediatricians and Associates, the board now recognizes those activities. So there's lots of ways to get your MOC credit, but you don't have to go out to the board to get the answers. We are portfolio sponsored here, and we will work with teams across the hospital to get us to where we all need to be. Mary and Robin, you want to help finish up?
We wanted to take this time just to answer any questions that anybody had or any comments.
Thank you all for a wonderful presentation. I do want to make one comment. Most of us in the room here, and myself included, are very involved with quality improvement initiatives on a day-to-day basis. It drives a lot of the work that we do, for example, in health information technology. And to our board representatives, what I would say is there are still some significant barriers to translating that good work into credit. My own personal experience over the last couple of years is, even though there were quality improvement initiatives that resulted in local, regional, national presentations, and even publications, trying to get that through the ABP in a timely manner and get approval for that is quite challenging. And it's not unusual to be rejected several times in the process there. So anything that we can do to try to grease the skids and translate some of that great QI work into credit would be greatly appreciated.
So, and I appreciate that feedback, and that is in large part why I was enthusiastic when Mary asked me to participate in this. If you find barriers, please let me know. Don't be shy about that, because I will tell you the board is interested in this feedback and very responsive to this feedback. So Dr. Nichols, who is the president of the ABP, he understands that we will not be successful unless you all feel that this is a process that works for you as well as children.